Thank you so much. So I am Angelica Hirschberg. I am gynecologist and professor from the Karolinska Institute and the Karolinska University Hospital in Stockholm, Sweden. This lecture will be about long-term effects of polycystic ovary syndrome. PCOS is considered the most common endocrine disorder in women of fertile age, with a prevalence around 10%, but that is depending on the definition. This syndrome was first described by two American gynecologists, Stein and Leventhal, in 1935. And they presented the clinical features of 7 women with anovulation, hirsutis, obesity, infertility, and polycystic ovaries. And since these patients all had severe symptoms, the diagnosis became quite stigmatized. However, today we know that it is a heterogeneous disorder with a spectrum of symptoms of varying degree between women, but also for an individual woman over time. This picture illustrates the pathophysiology of PCOS. And the two cornerstones are hyperandrogenism and insulin resistance. And they can explain the various symptoms of PCOS. The clinical consequences of hyperandrogenism are anovulation and also the typical polycystic ovarian morphology, leading to reduced fertility and hirsutis. Women with PCOS also have an increased occurrence of insulin resistance independent of obesity, leading to secondary hyperinsulinemia. And this will, could together with LH, stimulate directly testosterone secretion from the theca cells in the ovaries. And insulin resistance may cause metabolic symptoms, including abdominal obesity, that predisposes to type 2 diabetes, hypertension, and hyperlipidemia, the complete metabolic syndrome. And besides the direct stimulation of insulin on testosterone secretion in the ovary, insulin also inhibits the production of sex hormone binding globulin in the liver. And this will lead to increased levels of free testosterone, which is bioavailable. And testosterone may in turn induce insulin resistance by facilitating catecholamine stimulated lipolysis in visceral fat tissue, which could result in hepatic insulin resistance. And in this way, the endocrine disturbances will be reinforced and aggravate with more weight gain. However, it is still unclear whether hyperandrogenism or insulin resistance is a primary defect in PCOS, or if it is the combination of both factors which is important for the development of the syndrome. And this slide illustrates more clearly the various symptoms related to either hyperandrogenism or insulin resistance. And thus, hyperandrogenism is associated with the typical features of PCOS, such as hirsutis, oligomenorrhea, amenorrhea, reduced fertility, and polycystic ovaries. But as you can see, metabolic symptoms related to obesity are also very common. But despite this, metabolic symptoms are not included in the criteria of diagnosis, which I will come back to. The etiology of PCOS is largely unknown. However, several etiological factors have been proposed, including genetic causes, androgen programming in utero, as well as environmental factors. And for instance, twin studies and increased familial occurrence of PCOS speak for a hereditary component of the syndrome, but no single genetic defect has been detected, and therefore PCOS is considered a polygenetic disorder. Furthermore, experimental animal models also indicate that the hormonal environment during fetal life may predispose for later development of PCOS. And moreover, weight gain and obesity seem to be of great importance for the development of PCOS. In recent international guidelines, the criteria of the Rotterdam Consensus of 2003 were considered the best evidence-based diagnostic criteria. And according to Rotterdam criteria, the diagnosis of PCOS includes at least 2 of the 3 following features: oligo or anovulation, clinical and/or biochemical hyperandrogenism, and polycystic ovaries on ultrasound. However, it is important to exclude other hyperandrogenic disorders, including the mild form of congenital adrenal hyperplasia, Cushing syndrome, acromegaly, and virilizing tumors. Based on different combinations of PCOS criteria, 4 different phenotypes can be distinguished. And phenotype A has all 3 criteria: hyperandrogenism, oligoamenorrhea, and polycystic ovarian morphology. Whereas phenotype B has hyperandrogenism and oligomenorrhea, and phenotype C, hyperandrogenism, polycystic ovarian morphology, and phenotype D, oligoamenorrhea and polycystic ovarian morphology. And this last phenotype has sometimes been questioned: is it really PCOS? Since no symptoms of hyperandrogenism is included, and it has sometimes been called for light PCOS, so to say. PCOS is probably the most common endocrine disorder in women of fertile age. But with the initial NIH criteria, the prevalence was reported to be 6 to 10%. And with the Rotterdam criteria, which have extended the definition, the prevalence is about 15 to 20%. And the prevalence also varies depending on ethnicity. So high prevalence has been reported in ethnic groups of Mexican, Indian, and Aboriginal origins, while the prevalence in China is relatively low. This figure illustrates typical PCOS symptoms throughout life in women with PCOS. And for instance, in adolescence, menstrual disturbances, hirsutism, and overweight obesity may dominate, whereas later on, fertility problems with difficulties to become pregnant may be the most important. But furthermore, for instance, mood disorders may appear. In perimenopause, metabolic symptoms related to obesity may develop, including hypertension, hyperlipidemia, glucose intolerance, type 2 diabetes. But in this age also obstructive sleep apnea can appear. However, very little is known about how all these typical symptoms of PCOS develop in postmenopausal age in these women. So what about lifetime fertility in PCOS? Well, we know that fertility improves by age with 30% of normalized ovulation. And actually, there is no difference in lifetime parity between PCOS women and controls. And this could be explained by loss of follicles by age and decreased ovarian volume, PCO morphology disappears, and androgen levels decrease. And this will lead to more regular menstrual cycles, which are ovulatory. And at the same time, we know that women with PCOS have greater ovarian reserve and prolonged fertility period. Menopause is estimated to be 2 years later than the normal population. And this is illustrated here in this figure from the study by Turan et al. 2010. And here you can see women with PCOS as red circles and the controls in green. And you can see that the lines are separated and that AMH is decreasing much slower in women with PCOS. So what about long-term health after menopause in these women? They have many features which include hirsutism, obesity, type 2 diabetes, cardiovascular risk factors and disease, obstructive sleep apnea, endometrial cancer, breast cancer, depression, and anxiety. And in general, very little is known about the effect of menopausal transition and the long-term health consequences of PCOS. If I start with hirsutis, there are very few reports on the lifetime course of hirsutis. But in a Swedish long-term follow-up study, they showed that hirsutism was still more prevalent in women with PCOS at mean age 81 years than in controls. And they found that 1/3 of the women had hirsutism versus 4% in the control group. And they estimated hirsutism using the Fermat-Galway score and defined hirsutism as a score of 5 or greater. What was interesting was that they had this hirsutism, although androgen levels were comparable between groups and had decreased by time. Obesity is also common in women of PCOS, although it's not included in the diagnostic criteria. But according to a systematic review by Lim et al., the estimated prevalence of obesity in premenopausal women is around 50%, and particular central obesity is characteristic. And this is illustrated here in the figure by the apple form in this woman. And middle-aged women with PCOS have still higher BMI and waist circumference than age-matched controls. However, in older women, there was no significant difference in BMI and waist-hip ratio between women with PCOS and controls. Thus, the difference in obesity between PCOS and controls in obesity seemed to diminish by age. So we know that increased weight will result in increased insulin and insulin resistance, and this may induce a vicious circle of endocrine abnormalities and will, among other things, aggravate metabolic complications like different metabolic disorders and type 2 diabetes. So what about type 2 diabetes? We know that this is a consequence of long-standing insulin resistance. And it is known that, it's well known that PCOS is associated with increased risk of type 2 diabetes. And in a meta-analysis of Kassar et al., premenopausal women with PCOS had about 3 times increased risk of type 2 diabetes. However, most studies in postmenopausal women with PCOS show no significant increase in type 2 diabetes compared to controls. So that seemed to be an increased risk, so there seemed to be no increased risk of type 2 diabetes in postmenopausal women with PCOS. So what about risk factors for cardiovascular disease? A recent meta-analysis reported increased prevalence of hypertension in premenopausal women with PCOS, but not in the postmenopausal group. So once more, it seems that the increased prevalence of hypertension ameliorates with aging. Another meta-analysis showed impaired lipid profile in premenopausal women with PCOS compared to controls. But we have no data or insufficient data regarding dyslipidemia in postmenopausal women. The metabolic syndrome is a cluster of different symptoms, including abdominal obesity, insulin resistance, hyperlipidemia, and hypertension. And women with PCOS have increased occurrence of these individual components. So it's no wonder that they have increased prevalence of the metabolic syndrome, as demonstrated in this meta-analysis by Lim and collaborators, showing increased prevalence with odds ratio 3.4 compared to controls. However, perimenopausal women with PCOS seem not to have an increased prevalence of the metabolic syndrome, and data in postmenopausal women is lacking. So what about cardiovascular disease? Well, although premenopausal women have increased prevalence of risk factors for cardiovascular disease, meta-analyses have shown no increased risk of cardiovascular disease in pre- or postmenopausal women with PCOS. And this includes myocardial infarction, stroke, coronary heart disease, and cardiovascular mortality. So how can we explain this discrepancy between having risk factors for cardiovascular disease but no increased risk of disease? This is very interesting. Well, this figure illustrates different hypotheses. Hypothetically, women with PCOS, as illustrated here in red, may improve after menopause regarding cardiovascular risk factors and disease, at the same time as the controls deteriorate, as you can see here. Alternatively, women with PCOS do not improve but remain on the same level, whereas controls deteriorate more after menopause. So in this case, it seems like the controls catch up with the women with PCOS after menopause. And these different lifetime courses in women with PCOS and controls have not been clarified yet and need further investigation. Obstructive sleep apnea is another symptom that has been noticed in women with PCOS. And it is a chronic disorder characterized by recurrent upper airway obstructions during sleep, leading to intermittent hypoxia. And a recent meta-analysis showed increased pool prevalence in premenopausal women with PCOS. However, data in postmenopausal women with PCOS is lacking. What about cancer risk in women with PCOS? Well, several meta-analyses have demonstrated a 2 to 6-fold increased risk of endometrial cancer in women with PCOS. And this increased risk is usually explained by unopposed estrogen stimulation of the endometrium during anovulation and lack of protection by progesterone. However, the association is complex with many potential confounders, including obesity, type 2 diabetes, infertility, and treatment. Anyway, some studies indicate that the increased risk of endometrial cancer may be attenuated after menopause. Interestingly, women with PCOS have no increased risk of breast cancer, although the risk of endometrial cancer and breast cancer is connected and is also associated with obesity. And there is a hypothesis that maybe androgens are protective against breast cancer, but that needs further studies. Furthermore, women with PCOS have no increased risk of ovarian cancer. PCOS is also associated with increased risk of depressive and anxiety symptoms, as shown in this meta-analysis by Kuhn et al. And you can see the odds ratios are quite high. And the underlying causes of these mood disorders are not clear. A few longitudinal studies have demonstrated that the risk remains at least up to perimenopausal age, but data in postmenopausal women with PCOS is lacking. So how do we manage symptoms in peri and postmenopausal women with PCOS? First of all, symptoms of hyperandrogenism and for endometrial safety. Well, prolonged use of combined oral contraceptives could be an option, at least for women of perimenopausal age, if there are no major risk factors for thrombosis or coronary heart disease. However, it's not recommended to start this treatment in later age. And as an alternative to combined oral contraceptives, anti-androgens like spironolactone could be used for treatment of hirsutis. For endometrial safety, combined oral contraceptives could also be used. And as an alternative, cyclic progestogen could also be used for endometrial safety. However, metformin is not efficient as treatment for hirsutism and has no protective effect against endometrial cancer. And what about management of obesity-related metabolic disorders in these older women? Well, lifestyle intervention should always be the first choice of management. Metformin alone, or even better in combination with lifestyle intervention, is also an option. However, for those with severe obesity, bariatric surgery is an alternative. Furthermore, specific treatment for hypertension, hyperlipidemia, and type 2 diabetes may also be needed. So here are my take-home messages for women with PCOS after menopause. Symptoms of hyperandrogenism like hirsutis seem to persist although androgen levels decrease. Increased prevalence of obesity and type 2 diabetes in premenopausal women with PCOS seems not to remain after menopause. And although cardiovascular risk factors are increased in premenopausal women with PCOS, there is no increased incidence of cardiovascular disease or mortality in pre- or postmenopausal women with PCOS. Furthermore, women with PCOS have increased risk of endometrial cancer, but no increased risk of breast cancer or ovarian cancer. Mood disorders probably remain up to at least perimenopausal age in women with PCOS. Increased knowledge is clearly needed to understand and manage long-term health consequences in postmenopausal women with PCOS. So thank you so much for your attention. And I would also like to announce a next webinar on the 25th of March, when Professor Serge Rosenberg will have a presentation about menopausal patients, the most common challenges for treatment. Thank you so much.
Thank you so much, Dr. Hirschberg, for such a wonderful presentation. And now for the Q&A session, we will wait for a few seconds. I remind you that you can submit your text questions at the questions panel in your webinar control panel. Okay, see, all right, we have one question from Maureen Busby. She says, great to see psychological impact of PCOS mentioned. As a patient advocate, this is one aspect that is often overlooked among women with PCOS.
I really agree, but we need even more data, and also in older women with PCOS. So we really don't know the lifetime course of the development of these disorders. And we don't know either how they develop and other associated factors. We know that hirsutism and obesity are symptoms linked to depression and anxiety, but we certainly need more knowledge about this.
Mhm. And her question is, which progesterones can be used for postmenopausal women? Medroxyprogesterone or Cerazette, sorry, etc. One of those?
Oh, that's a good question. And actually, we don't have much data about this. But for menopausal hormone therapy, I think natural progesterone has shown we seem to be perhaps more beneficial than most of the progestogens, which we know can cause, for instance, premenstrual symptoms and depressive symptoms and so on. So for menopausal hormone therapy, I think I would suggest to use natural progesterone. And for combined oral contraceptives, I mean, we had some data for drospirenone containing OCs, which seem to be beneficial.
Okay, and our next question is, do you have any information about skin symptoms? Do they also ameliorate by age?
Not no specific data. I mean, it was quite surprised to see that hirsutism does not improve by age while androgen levels decrease. And this we do not know about. Usually acne improves, but why hirsutism does not improve, we do not know. If it can be an increased androgen receptor sensitivity in these women as well or not. But usually acne and oily skin will improve by age. But I suppose body weight is also very important for how much skin symptoms you will have. And I mean, it's well known that skin symptoms improve if the woman do not gain in weight.
All right, thank you. Our next question is, how long anti-androgens as spironolactone can be used for hirsutism and in what dose?
Yes, I think it can be used for a long time. I mean, it's a medication we know really severe side effects. Of course, you have to control electrolytes. But otherwise, and what is good for these women is that usually they have increased blood pressure, and spironolactone is an antihypertensive medication. So with this treatment, you can both control the blood pressure, but also it is also a treatment for hirsutism. And I usually use a dose of 50 milligram daily, and I very, very seldom increase this dose. And I think 50 milligram daily is quite efficient, but it's important to explain to the patient that it will take time before they can see any positive effect. It comes earliest after 6 months of treatment, and sometimes the full effect comes much later after a couple of years and so on. So they must understand that this is for long-term treatment. But in my opinion, spironolactone is a quite efficient medication with few side effects.
All right, we have a few more questions actually. Should we stop counseling women with PCOS about increased risk of CV mortality?
That's a very good question. And of course, as long they have the risk factors for cardiovascular disease, we have to continue to follow that, for instance, hypertension and hyperlipidemia and so on. But at the same time, we do not need to worry more than necessary. And I think it's a quite positive message that although they have these risk factors, in the end, it seems not to mean an increased risk of disease. But still, we do not really know why it is like this. Is it that the healthy control women, that they, so to say, catch up after menopause? Or could it be that women with PCOS also have some protective factors? We don't really know that, so we need more knowledge about it.
All right. Next question. Do anti-androgenic progesterones have an edge over other preparations?
No, I didn't get the question. Could you repeat it, please?
Oh, yes, of course. Do anti-androgenic progesterones have an edge over other preparations? Are they better?
If they are better, actually, there are quite few studies comparing different anti-androgenic treatments, so we do not know. And I think it's wise to use the medications that are not associated with severe side effects, for instance, that could affect the liver function and other side effects. But we need more data on this too.
All right. Our next question is, do you think inositols would be safe to take postmenopausally for PCOS symptoms?
That's an interesting question. I think inositol, which is quite similar to the effect of metformin. There are several studies in premenopausal women showing some beneficial effects. But to my knowledge, I'm not aware of studies in postmenopausal women. But I think for sure it could be safe to use that in postmenopausal women, because what we know from the treatment in premenopausal women, there are no severe adverse effects by this. So I think for sure we can recommend it.
Okay. Oh, we have more questions. Besides anti-androgen COCs, is there other therapeutic options against skin symptoms? Sorry.
I mean, other anti-androgens, of course, can also be used for skin symptoms like spironolactone. But then there are also other options like cyproterone acetate. But recently we was aware of that there is an increased risk of meningioma using high doses of cyproterone acetate. So we should be aware of this risk. So in my opinion, spironolactone is the best alternative if we cannot use combined oral contraceptives, for instance, in older women. But then we have other options, of course, also 5-alpha reductase inhibitors and so on. But I think if we use either combined anti-androgenic oral contraceptives and spironolactone, we have a good treatment for most of women with either hirsutism and acne.
All right. So our next question, how long can metformin be used?
I mean, metformin is a medication with no really I mean, it's uncommon with really severe adverse effects, so it could be used for long-term treatment. And for especially in women with metabolic disturbances, metformin is not a treatment for hirsutism, for instance, and it's not for protection of the endometrium. But for a woman with obesity and obesity-related metabolic symptoms, it could be very beneficial. And some women, they also they find it easier to control weight by using metformin. It's not a medication which results in weight loss, but for some women it could be easier to control body weight by using it.
Right. Our next question is somehow related to metformin. Would you prescribe metformin in women with PCOS with no evidence of impaired glucose tolerance? Is there any evidence to suggest that they benefit from it?
It's a very good question, and actually there is no evidence of long-term use of metformin in PCOS, but we have quite long experience of using it, but there is no scientific evidence, to be honest. But I mean, if a woman has obesity, they may not have glucose intolerance, but they for sure have insulin resistance. So if there is no contraindication, I will consider metformin treatment for obese women. And especially those who are so obese that we cannot offer them combined oral contraceptives.
Okay.
Mm.
It was very interesting that you mentioned that fertility might improve after age of 30. Should this aspect be considered in terms of family planning? One more.
Yes, that's also a very good question. I mean, I think many gynecologists and other doctors have experienced that a woman with PCOS, she may have struggled to become pregnant for many years, and she may succeed with IVF. And after, when she's 35 years of age or something like that, suddenly her menstruations become regular and she will ovulate spontaneously and she can become pregnant spontaneously. That is not seldom at all. But we cannot recommend women with PCOS to wait too long with a planning of pregnancy, because at the same time the egg will I mean, they will undergo aging and they will become older, and the quality, the egg quality will impair by age. So therefore, I would not recommend these women to wait too long to become pregnant.
Okay. And what is your opinion about Tibolene in PCOS women? Might this treatment be beneficial?
It depends on in what aspect. I mean, Tibolene contains has also some androgenic activity, and that could be beneficial for sexuality and libido and so on. But usually women with PCOS, they want to diminish androgen activity as much as possible. But of course, for an individual case, it could be beneficial, and particularly if she experiences decreased libido and sexual dysfunction.
Okay. Does PCOS resolve after menopause?
Pardon, I didn't.
Does PCOS resolve after menopause?
Resolve, I mean, the symptoms related to ovulatory function will of course resolve. I mean, after menopause you have no more menstruation, but as I presented today, hirsutism will not resolve. Unfortunately, hirsutism may remain, and also the metabolic symptoms. So actually, most of the symptoms remain, but for the metabolic symptoms, I think body weight is very important for the development of metabolic symptoms. If the woman is normal weight, she certainly have less problems with the development of metabolic symptoms.
Okay, and our last question for today is, what is the treatment for androgenetic alopecia in postmenopause?
I mean, unfortunately, we do not have any good treatment for alopecia, in my opinion. And as far as I know, there are no specific studies in postmenopausal women with this symptom. And what usually is recommended is some kind of anti-androgenic treatment. And for instance, 5-alpha reductase inhibitors. But according to my clinical experience, we cannot expect good treatment effect if the patient already has developed alopecia. So that is unfortunately one of the symptoms that we cannot, we do not really have any efficient treatment, unfortunately.
Okay, well, one more question just came in. What about osteoporosis and risk of major fractures, considering the effects of androgens on bone?
I mean, androgens are considered to have beneficial effects on bone mass. I mean, there are androgen receptors in bone which could stimulate bone proliferation. So usually women with PCOS have very strong bone and high bone mineral density. So usually this is not any big problem. Even if they are treated with anti-androgens, they used to have high bone mineral density, and that is also related to, of course, I mean, obesity also has a beneficial effect on bone mass.
All right. Thank you so much, Dr. Hirschberg. It seems that we do not have any questions. Thank you so much for an amazing Q&A session. Are there any final thoughts you'd like to leave us before ending today's webinar?
No, and thank you for those who listened and for all very good questions.
All right. So this concludes the webinar. Once again, thank you so much, Dr. Hirschberg, for your presentation and all the attendees for being here today. Have a great rest of the day.
Thank you.